Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Welcome back to Endocrine Matters. I'm your host, Dr. Arti Thangudu, and today we're doing something a little different. We're bringing you inside a real endocrinology journal club, but in a way that's practical, relatable, and meaningful, whether you're a clinician, trainee, or someone living with obesity or metabolic disease. I'm joined by two incredible endocrinologists and colleagues, Dr. Vidhya Illuri and Dr. Munira Mehta, and together we're breaking down a major new study published in the New England Journal of Medicine on oral semaglutide for weight loss. We'll walk through how this randomized placebo-controlled trial was designed, why placebo matters, and what the results actually show, and what this means for real patients, especially when it comes to access, side effects, dosing, and the importance of having a knowledgeable prescriber guiding your care. If you've been hearing a lot about GLP-1 medications and wondering what's real, what's hype, and how this applies to everyday endocrine practice, this episode is for you. Let's get into it. Welcome, Munira and Vidhya. I'm so happy to be here with you guys today. These are some of the smartest ladies I've ever met, and I'm so thrilled that they're on my team and here with me today. I'm going to start by just asking a few questions to get the conversation flowing, and then we'll kind of see where it takes us. And just so you guys know, Vidhya and Munira are both physicians, both endocrinologists, and board certified in endocrinology. So we're really happy to give you guys this insight into what a journal club is, how we think about studies, how we think about medications, and whether they're appropriate for our patients. So let's go ahead and get started. So my first question is to kind of set the stage. So first, can one of you briefly summarize this study for our audience? Like, what questions were the researchers trying to answer? Why is this an important study, and why is it important for obesity medicine in general? I know that's a big one, so both of you guys can take a stab at it.
I can go. So we know that injectable semaglutide has been approved to treat both type 2 diabetes as well as obesity. Oral semaglutide has previously been approved for the treatment of type 2 diabetes. So this study was looking at if oral semaglutide could also be effective to treat obesity and result in clinically significant weight loss. And this is really important because we know that obesity is increasing in prevalence, and this leads to other chronic metabolic diseases such as hypertension, diabetes, high cholesterol, fatty liver disease. So finding effective treatments for obesity is really relevant and important. Plus, having an oral option is very important.
Yeah, and I would love for you to tell our audience who may not know, what do you see as clinically significant weight loss? Why does that matter?
We know that even a 5% weight loss can lead to improvements in hypertension, hyperlipidemia, type 2 diabetes, and fatty liver disease. So any medication that can lead to that type of weight loss is going to be really interesting for our patients and us, because we know that can help our patients prevent all these chronic metabolic diseases.
Dr. Mehta, do you have anything to add to that?
No, that I agree with what Dr. Illuri said, and I wanted to touch on a bit about what the researchers looked at from the standpoint of primary endpoints. What were their primary goals of the study, as well as the secondary endpoints? So the primary goal, as Vidhya talked about, was of looking at the percentage of patients in the treatment group versus the placebo group that were able to reach at least a 5% body weight loss, as well as in the secondary endpoints, they looked at what percentage of patients were able to reach a 10%, 15%, 20% weight loss. And they also looked at their physical function score and their quality of life at the end of the study at 64 weeks, in addition to metabolic changes and parameters that were measured as part of the study.
Yeah, and I think it's really important to stop and discuss obesity as a metabolic disease because I think there's a lot of cultural stigma around obesity. Some people think weight loss medications are cosmetic medications, but like Dr. Alluri said, weight loss in people who have obesity, so what this study called obesity was a BMI greater than 30 or a BMI greater than 27 with a comorbidity of obesity. Um, we know we don't love BMI, but that's kind of the standard right now. Who knows if that will change to body composition measures in the future? But so clinical obesity, we know that people who are living with that um, do have higher risk of metabolic diseases, high blood pressure, diabetes, those types of things. So weight loss is not just a cosmetic thing. People like to be thinner. It's a we want people to feel good about their bodies, of course, but it's more than that. It's about preventing complications of obesity, of preventing diabetes, heart disease, things like that that are very burdensome to families, to people, to our healthcare system, all of the things that we want to decrease the burden on. So, and obesity is a chronic disease. It's a relapsing, remitting chronic disease, just like something like diabetes or high blood pressure. So there has also been this thought about, oh, well, these medications don't really work because you have to take them for a long term. And many people do have to take them for a long term. Some people are able to come off of them. But when you think about obesity as a chronic disease, we don't get upset that somebody's blood pressure goes up if they don't take their blood pressure medication, right? We expect that because we understand high blood pressure, hypertension as a chronic disease. And we need to look at obesity the same way. If you take away the thing that's treating the obesity, well, yes, it's more than likely going to come back. There's some things, some lifestyle changes that we can implement that might make it less likely. Same with high blood pressure. If we make some lifestyle adjustments, they may be able to get off their medications. But I do think that that's a really confusing conversation that is just rampant around this medication class because there's so many people out there trying to say they don't work. And that's simply not true. They may not work for every single person, but based on our clinical experience as well as what the data shows, they do work when they're used correctly and appropriately. Okay, so just to go over this study in a little bit more detail. So it was a randomized placebo-controlled trial. Do one of you guys want to break down what that means?
Yes, so it means that there were two groups that were looked at in the study. So one group actually got the drug, the oral semaglutide, and then the other group got placebo. And what placebo means is it's just a small pill with nothing in it. And there is a really good reason to do that because then you know that both groups in the study, they don't know if they got the medication or they didn't get the medication. So there's not bias from the groups, the participants, and also the people studying those participants or following them up clinically also didn't know if the participants got placebo or the actual drug, the actual medication. So we know or we hope to see that if there is a clinically significant amount of weight loss compared to the placebo group, we know that the reason for the weight loss was the medication and not some other confounding variable. So it's really helpful to always have a control group compared to the intervention group. So you're actually comparing apples to apples and know that the one thing that's different is the actual medication. In this study, both of the groups were getting the same amount of follow up and the same amount of dietary advice and support. Whenever you're looking at a new medication, it's just really good to compare it to like an evenly matched control group so you actually know what the medication is doing for the participants.
Yeah, so I think when we say double blind, that means the participant and the researcher doesn't know who is in the placebo group and who's in the treatment group. And that's really important because there may be biases, right, that are subconscious in the commitment someone has to their diet and exercise. If they're on the medication, they may be more or they may be less committed, depending on the person. Same with how the researchers would possibly treat the treatment group versus the non-treatment group if they're biased to want a certain outcome. So that's why this blinding is really important, or a few of the reasons why it's really important. Dr. Mehta, would you like to talk a little bit more about how important and interesting it is that both groups, the treatment group and the placebo group, had the same dietary counseling and the same exercise counseling?
Yes, absolutely. And I think that's so important. And I think Vidya touched on some of this, is we're trying to remove other variables that may impact the results of the study. So, for example, if the treatment group was given a more intensive lifestyle modification regimen compared to the placebo group or vice versa, that would confound the results of the study. And to avoid that and to allow a fair comparison and a fair statistical analyses, they try to keep all the other variables very similar, and they had exactly the same intervention in terms of dietary advice, as well as 150 minutes of exercise per week. And so, in order to avoid those confounding variables, it's important that a good study looks at all of these factors when they design the study, in order to get the most accurate results. And also, you don't want to skew the results based on, if the treatment group gets more intensive lifestyle changes, then that would skew the results of the study. And all of these things are so important when you look at a high quality study and you're looking at the statistical analyses and the statistically significant results that come out of it.
Yeah, and I think this is really important because we live in a world of anecdotal evidence, right? There's a
Mhm.
lot of people telling their story, right? Which is great. Like I live for people's stories. However, everybody's story has confounding variables. So if, for example, X diet or X medication worked for your mom, your sister, your friend, that doesn't necessarily mean it's going to work for you. Or let's say there's an influencer selling their program or their tea or their detox or whatever that doesn't have rigorous study behind it. Well, there are a lot of confounding variables that could have made it work for one person, but make it really dangerous for another person or just ineffective for another person. So that's why in medicine, we're always talking about the evidence. And I don't think that the evidence is the end all be all. Like, I think there are things that we learn as in our experience as clinicians. Not every patient fits the same criteria as the patients were in this. So of course, there is some nuance to how we choose to treat patients, but this is how these studies are how we determine whether the baseline of safety and efficacy, so whether the medication works, is there. And then after knowing those details of a study, we have to put in the nuance of what we know about our own patient in front of us, knowing what the evidence says. It's not enough to just know the patient, right? We have to know the rest of it, like what the science says, and then we have to be able to assimilate that with what we know about our patient and synergistically make a decision to keep our patients safe, which is always the number one priority of your physicians who are practicing with ethics. A little bit more about the study. So there was about 300 participants. 205 were assigned to the treatment group. 102 were matched placebo recipients. So not a enormous study, but several studies. And size of a study really powers it, right? It tells you that, okay, this didn't just happen in one or two people, this happened over a large population, which goes back to kind of the anecdotal stuff, right? Like, just because something happens in one or two or 10 people, that doesn't necessarily mean it's statistically significant or applicable to everybody. So that's one reason that these studies are so challenging to do because you have to recruit all these people to do them, and they're expensive, and it's not easy for every small supplement company to do that, right? Munira, do you want to tell us a little bit about the participants
Sure.
in the study?
Yes. So they studied, like she mentioned, the numbers that were studied. The average age was about 48 years of age, and the female demographic was about 75%, and the rest were men. The average body weight was around 106 kilos for these patients, and 92% of the patients were of race or ethnic group that they were white or Caucasian. There was a 6.3% smaller minority of Black patients, very small Asian and other ethnicities. The BMI category, majority of the patients fell in the BMI category of 35 to 40, with a few that were under 30 with comorbidities, and a few greater than 40 and a few between 30 and 35. And the A1C, this was interesting. The average A1C was 5.7%, which is considered to be prediabetes. 50% of the patients had prediabetes in the oral semaglutide group. And because we call it a matched placebo, the demographics, the characteristics were very similar in the placebo group as they were in the treatment group.
Yeah, and then Vidya, will you tell us a little bit about the doses they used and kind of compare that with the doses used for diabetes and the doses that are now available for oral semaglutide? Because I think that's a little bit confusing because
It is.
the doses are a little bit different.
Mm-hmm. The medication dosage for this study was actually the type 2 diabetes medication doses, which is Rybelsus. So it was 3 milligrams, 7 milligrams, 14 milligrams, and then the last dose was 25 milligrams.
And that one was the new dose.
And that's the new dose. So the type 2 diabetes medications, Rybelsus, is only available in the 3 milligrams, 7 milligrams, and 14 milligrams. So kind of this new dose that we're excited about is 25 milligrams. And that is really what they studied. Their aim in this study was to get everyone to the 25 milligrams by the end of the titration. And they went up on the dose every 4 weeks.
Yeah, and the reason that they wanted to try for higher is because Rybelsus was not shown to have clinically significant weight loss. And there was another study that showed that there was clinically significant weight loss with semaglutide 50 milligrams. So the thought process is like, well, could we get clinically significant weight loss for a lower dose than that? And the reason why we think that we need higher doses when we take it orally is because like the enzymes in the stomach and the acid can break down some of the peptide versus when you give it as an injectable. So like the injectable Wegovy goes up to 2.4 milligrams, which is much lower than, of course, the highest dose of the oral. So now, though, with oral Wegovy that is commercially available, it's been available for a couple of weeks. Today, we're recording on January 21st, 2026. The doses actually start at 1.5 milligrams and go from 1.5 to 4 to 9 to 25 milligrams. And the recommendation is to increase every 4 weeks, as long as the patient tolerates it well. So the doses in the study are slightly different from what we have commercially available. And that's not there to confuse you. It's just because those are the doses that were available at that time. And the study results can still be relayed because we are really moving toward that 25 milligram dose, clinically and also in this study. So that's the same. Okay, so the fun part, let's talk about the results. So what did we find? What were the results significant? And what did you think about them?
This is exciting, right? So when they compared weight loss in the placebo group to the semaglutide group, the placebo group had a a negative 2.2% in weight reduction. And then the semaglutide group got a negative 13.6%. So there was an 11.4% difference from the placebo group to the oral semaglutide group. So that's very exciting because we're actually seeing weight loss with this. And just to compare, the highest injectable Wegovy group in that study, the difference was 12.4% more than placebo. So you can't there's not a study comparing the oral semaglutide to the injectable, but we still have that information from previous studies to realize, hey, this is actually a pretty good drug. Like there is weight loss with it.
Yeah, and that was including the people who discontinued the medication. There weren't a whole lot of people who had to discontinue the medication, but when they kind of extrapolated to all of the people who were able to tolerate the highest dose, they estimated it would have been like a 16.6% weight loss with the semaglutide group. So if you can get all the way up to 25 milligrams, you'll probably see a better weight loss result than if not. So yeah, I think this is really exciting because having an oral weight loss medication that is well tolerated and effective is a huge game changer because with the injectables, well, one, a lot of people hate injections, but also the storage requirements, the refrigeration requirements for injectable medications, the space required to store it on a warehouse level, pharmacy level, even home fridge storage can get pretty dicey and expensive. So having a daily oral pill just is such a huge game changer. Also, I have plenty of patients who travel and it's always like, okay, how do I take my Mounjaro or Wegovy pens with me, you know? And so having a pill that you can just add to your pill box is a lot easier for a lot of patients. And just the practicality of having a pill is so much easier. I also think that having another GLP-1 receptor agonist in the game increases options for patients, but also can move pricing because now we have an oral stable formulation, you know? So usually orals are less expensive than injectable medications generally also, and the price point for this medication is starting out much lower than where our injectables started and where our injectables even are now. So I think that's really exciting. But before we go too deep into why we're so excited about this, I think we need to talk about the side effects and how those were explored, what they saw, what were the common side effects. Dr. Mehta,
Yeah,
would you like to talk a little bit about that?
sure. One of the biggest side effects, as expected, with this oral GLP class, which is similar to the injectables, was nausea, and that was seen in about 46% of the patients. And interestingly, in the placebo group, it was seen in about 19% of the patients as well. And then there was some incidence of vomiting in the which was higher in the treatment group compared to the placebo group. Some other side effects included some constipation, dyspepsia, a low incidence of headaches, but primarily it was the nausea that was the side effect that was experienced the most by the treatment group.
Yeah, and I think that it's interesting because in our experience, we've definitely seen side effects of nausea with this class of medications. But I thought one thing that was really interesting was 93.1% of people reported side effects in the semaglutide group, but 85.3% of people reported side effects in the placebo group, which just makes you think, like, why are these people having side effects? Because that's not even a 10% difference in people who aren't taking the medication. And it makes me wonder about like the psychology of people just taking a new medication, starting a new plan. What portion of side effect has to do with like the anticipation or anxiety related to doing something different and new? Of course, side effects are real, whether they're on placebo or on the treatment group in any study. Like, I don't want to dismiss side effects related to placebo effect. I like hate it when people are like, oh, it's all in your head, because that's not a thing. Like, if people are experiencing a symptom, then they're experiencing a symptom. However, I just think it's really interesting how many placebo group patients had side effects. The other thing that I thought was interesting is, yes, nausea is a common side effect, but the median duration of nausea was 13 days. That's less than 2 weeks. So if you're thinking about side effect, like risk versus benefit, a lot of people would take 13 days of nausea to have a 10% or 13% weight loss or more. And I think that there's a lot of media saying that these medications are making people, throw up profusely or like feel really ill. And what we're seeing in the studies is that's just not what we're seeing in the studies or clinically. I would love to kind of hear y'all's thoughts on what we're actually seeing clinically as far as nausea, vomiting, and cessation of these medications because of those things.
I think it there's so many things that play into why a patient is feeling the nausea or the vomiting. So first of all, it tends to happen when they're starting the medication, and it tends to resolve after sticking with a certain dose for a while. The other thing that we do that to be careful is we stick with lower doses for a while until nausea resolves before advancing to the next dose. If you advance too quickly, there is a higher likelihood that the patient's going to experience nausea or vomiting. The other thing is what they're doing lifestyle wise really impacts how much nausea and vomiting they get. So, for example, if somebody's also working with a dietitian, and they're following like maybe a higher fiber, lean protein, lower fat type of diet, they tend to experience less nausea and vomiting versus somebody who's eating a very high fat diet that tends, as we know, can slow down the gut. So clinically, I feel like if we stick to low doses and we have close follow up and our patients also working with a dietitian, that we can oftentimes minimize the nausea and the vomiting.
Yeah, and it's all personalized. So some patients may follow the protocol where every 4 weeks we increase the dose, but a lot of times it's frequent follow-ups, check-ins, and there's no rush. We can always slow things down and uh, have a more nuanced way to titrate the dose, which is why I think it's important to work with a physician who can see you on a regular basis and work with you to coach you through the titration protocol, and we can titrate it to minimize side effects.
Yeah, and I think that we've been prescribing these medications for a long time. I mean, I've been prescribing the like Victoza, which was one that we used to
Mhm.
use since I was a resident, years and years ago. So this issue with horrible side effects came to light when these medications kind of went viral, and a lot of people started prescribing them, which is great for access. Like, I'm not opposed to more patients getting access to these medications because I think Vidya and I went to a Texas endocrinology conference in 2021 or 2022, where Carolina Solis gave that amazing lecture. And at that time, I think it was probably 2021, um, she had like pharmacy records that showed that 90+% of medications, newer medications for diabetes, so GLP-1 receptor agonist, um, GLP-1 receptor agonists and SGLT2 inhibitors at that time, 90+% were being written by endocrinologists. And at that time, we were not seeing these reported side effects. But then I think it was 2022 when things started going viral. I think maybe Elon Musk and the Kardashians started talking about these medications. And then everybody wanted their hands on them. And it was just nuts when Mounjaro first came out. That's tirzepatide, they had this coupon card that anybody could get the medication. And I want to say it was like a $0 copay or like $25. It was incredibly inexpensive and anyone could get it. So there were literally hotlines where people could call and get a prescription for this drug. I don't know what kind of doctors were signing off on these prescriptions, but somebody was making a ton of money on prescribing these very unethically. And that's when we started getting like these New York Times articles about the side effects of these medications. I even had a friend who's a physician and her mom was prescribed Ozempic recently. And she's like, my mom's throwing up. What do I do? And I was like, well, what dose was she prescribed? And she was like, she was started on 1 milligram, which is like the third dose. So I was like, of course she's throwing up. She needs to, you know, not be on 1 milligram, and we had to figure it out. But like, there's so many prescribers, which is a good thing in theory, but it's really important to be prescribed by somebody who knows what they're talking about and is monitoring you. Like, access to your doctor is really important with these medications that's dose is changing, because a patient who is throwing up on the medication should be discontinued off of the medication. But what's really happening is people are either being increased on the dose, they're not being stopped, or they are so desperate for weight loss that they would want to be throwing up for the
Mhm.
sake of weight loss, and they're not getting counseled on the dangers of that, and people are getting really sick or ending up in the hospital because of that. um, so I think that while access to an oral is amazing and we want to increase access, we want to increase safe access and the correct access. Okay, so let's talk a little bit more about what we have available, what our experience has been in trying to prescribe oral semaglutide, because we're just starting to prescribe it, and how patients can actually get it from their doctors and their pharmacies.
So, it was approved the first week of January. So I've been prescribing it maybe since the second week of January. But there have been a couple of snafus, and I think that this is really common whenever there's a new medication. There's a demand for it. It's really popular, but maybe not all the pharmacies have it in stock yet or super updated. So so this tends to happen in the beginning. So I just have like an anecdote. I wrote it for one of my patients last week, and we sent it to her pharmacy. And I'm like, hey, it should be $149 if your insurance doesn't cover it, because that's what the price is for the first month. And her pharmacy said it was over $1,000, and it was just like, wait a second. So sometimes it is like practically like a communication issue. So sometimes you can know about these drugs and read all the data and just be an expert, but then you actually have to like find it and get it for your patient. So sometimes knowing the rep and getting some direction can be very helpful there. So the first two lowest doses, the 1.5 milligram and the 4 milligram dose, should be $149 per month for the first 2 months until April. Then after April, those doses are $199 a month, and then the 9 milligram and the 25 milligram dose should be $299 if your insurance doesn't help. So those are cash pricing without insurance. If you have like a coupon from the Wegovy website. One way that I got around with dealing with local pharmacies was prescribing to the Novo Direct pharmacy. That is the company pharmacy, and it's a mail order pharmacy. So patients can make an account with them and get the medication that way. But I also believe that, as time goes on, it'll probably be more available at local pharmacies, and people will know that it's out and be more aware that this medication is available for people.
Yeah, and I think it's so important to have a doctor who, one, is knowledgeable about the pricing, especially on the GLP-1s right now, because I would say 9 times out of 10, the pharmacies uh, misquote the patients. So even with not even just GLP-1s, but even with Freestyle Libre, Dexcom, our CGMs, like they quote them way more than the cash price, like hundreds or thousands of dollars more. So it's really important for you to have a physician or doctor who is knowledgeable about the pricing, to somebody who's willing to advocate for you, and someone who has the reps on speed dial, because we contact our reps every day. We love them. We hope they love us still, but yes, so $149 for the lower doses and $299 for the higher doses. Now in April, the lower dose pricing is going to go up. At least that's what we've heard so far from our reps. But if you go to the pharmacy and they quote you for more, don't just take it home with you and think they're going to give you a refund later, because they are not. They are going to take your money and run. So just say, no, thank you. I will contact my doctor to figure out how to get the pricing. You need a savings card at your local pharmacy to get the cash pricing. I hate this. It's stupid. It's like a trick, right? And then the other way to go around it too is the NovoCare pharmacy, which is an online mail order retail pharmacy that your doctor can send the prescription to. And then stock is a big issue too. Like, a lot of pharmacies aren't carrying it yet. They can order it, and it really depends. Sometimes you get a really proactive pharmacist or tech on the phone and they're willing to take care of it for you. And there's other people who are just trying to get through the day with doing as little as possible as they can. So try not to be discouraged. This is a new medication, and there's just hiccups that come with that as it becomes more mainstream and prescribed more often. Hopefully it will become smoother. And if you're really struggling, come see us. Like, we'll be happy. We love the opportunity to navigate this horrendous pharmacy and healthcare system for our patients, because it's really hard. It's like every time my blood boils with every patient experience, my own personal experiences. Like, I wrote a patient's prescription for an insulin called Tresiba just a couple of weeks ago, and then they told me it wasn't covered by the plan and that the patient couldn't get it, but they would release an emergency prescription because the patient was like traveling out of town. And then we worked on the prior authorization for it. And then they said the medication doesn't need a prior authorization and it was covered by the plan. And then the patient got a 3-month supply. Like, just nonsense all day, every day. Every prescription for diabetes and obesity is like this. So we hear you as endocrinologists. It's really frustrating to be a patient. And if you're struggling to have a clinical team on your side, we're happy to help in any way that we can. So this kind of takes me right into our next and final question. So bringing this back into our role as endocrinologists, how do we responsibly prescribe powerful medications like oral semaglutide and other GLP-1s, balancing excitement about weight loss outcomes with also like patient safety, education, and long-term follow-up?
Yeah, I think it's like you said, this is just another tool in our tool belt as far as pharmacologic options go for patients, and it really is a great option for a lot of patients who have needle phobias or stigma. There's still stigma associated with taking injectables, so it's a great option to have, but it needs to be balanced with the safety, and there are contraindications to taking this medications. Risks, benefits need to be discussed with patients. It needs to be very, we have to be upfront about the benefits, the results, and then it comes at a cost, and there are some risks associated with it, and those need to be discussed, and it needs to be an individualized decision. And we also take into account other treatment options and discuss that with the patient before it's not like we just prescribe it to anyone who asks us to prescribe it. That's our ethical responsibility as physicians to do it in a safe manner and effective manner. And then also monitoring metabolic parameters. It's not just about the number on the scale, but knowing the impact it has on your metabolic parameters, because that's what we care about, is reducing the risk of complications related to obesity, including cardiovascular disease, diabetes, prediabetes. So having a plan to begin with and then a follow-up plan is important.
Yeah, and we also care about your quality of life, right? We want you to
Yeah.
feel good in your body. And the interesting thing in this study is that patients' quality of life did improve when they studied it in both groups. A little bit more in the semaglutide group, but just the lifestyle intervention, the diet, exercise, perhaps the involvement in a study and the support that they were getting improved quality of life. And I thought that was really fascinating because a lot of times patients in a study get a lot more support than in a traditional clinic. And yeah, I think that's a really important piece of this puzzle as well. Dr. Illuri, did you have anything to add to that?
Yeah, I think just in terms of patient safety and education too, and gosh, we see it on the red carpet. Too many folks are taking this medication and the weight loss is very drastic, and it doesn't seem like they're getting the proper nutrition advice when you take these medications. And I think that is just like a really, really important piece of the puzzle that we do at Complete Medicine, because our patients have access to a dietitian, and also we discuss nutrition at every single one of our visits. But what I see too often with these medications is they are prescribed and patients have very little follow-up or education about what safe weight loss is and how to focus on fat loss but maintain muscle. And then we're just seeing really drastic results that are not safe and really not good for patients. It's not good to lose a bunch of muscle, right? Especially in patients that are dealing with diabetes or maybe a little bit older. So, these medications are super exciting because they help with weight loss, and that's a hot topic for everybody. But there really is safety concerns if they're used inappropriately. And that's why going to a clinic or seeing a provider that can have really frequent follow-up with you, along with lifestyle advice like weight training, exercise, what are you supposed to be eating, all of this goes with prescribing one of these medications.
And who is beholden to their ethics, and there are many, many people who are malnourished on these medications. We can see it. Dr. Illuri and I have talked about for years. We're like, oh, is this celebrity before anyone else knew about Ozempic, we're like, oh my gosh, this celebrity is taking Ozempic. Good for her. Oh no, she's getting malnourished now,
Yeah, we're like, I don't know that she needs it.
Yeah, I don't know if she needs it. But there are studies showing that these medications don't increase risk of osteoporosis, but you have to remember that low body mass can lead to osteoporosis, but the studies are done in people who are candidates for the medication. There are people with obesity who are on the medications. They have not studied these medications in people who are normal or low BMI, using these medications to further lower their weight to a place where they're malnourished, right? And so you can't extrapolate the study that says it doesn't worsen risk of osteoporosis in somebody who needs to lose weight for health reasons to somebody who is already a low weight who's using it to lower weight. And I'm really concerned. There's many people who I follow on social media or know that I'm like, oh my gosh, this poor woman is going to have osteoporosis because, and there are people who have openly said that they're using these medications to lose weight, and they're clearly malnourished at this point. And I really, really worry about their bones. And so I think that these medications cannot be used as a cosmetic drug primarily. Of course, people often feel better and feel like they look better when they are getting to a healthier weight. But if your weight is already at a healthy weight or low, these medications aren't safe to use. And so I'm really glad that Dr. Illuri, you brought up that point because, yeah, I really do worry about people's bones. Well, that's it for today. I hope you guys learned something, learned how we think about studies, how we evaluate the data when we are considering new medications for our patients. And if you have any questions, please don't hesitate to reach out. If you want to be our patient, check us out at essaycomplete.com. You'll have all the information there. And if you liked this episode, please follow us. We love and are so grateful for all of your support. And you can also find me at Dr. Arti Thangudu on Instagram. Thanks so much and talk soon.